everybody, it is Dietitian Zet here. Good day everybody, it's Dietitian Zet here and welcome to our Zetlife mini-series. So today we have one of our very special guests, Dr. Visser. So start off, tell us more a bit about yourself. What do you do for a living?
Elzette, I think it's quite obvious what I do for a living, but basically I graduated in '97 because we need a degree these days. Some people buy it from checkers these days, so I can honestly say that I have a degree from the University of Pretoria, '97. Then went and did 2 years of community service in the army, and then I started private practice. Bought this practice in 2002, and then you were so lovely to join the practice 2 years ago already, isn't
So
it?
happy, yes.
So that's basically it. And major things that I like to have as interests is I always thought that you have to do medicine and surgery because it's basically 2 degrees that you do. So I do theatre assistancies and I see patients. Although the theatre assistancies have become more dominant now, as you grow older, it is a fact that you basically then grow with the specialist that you work for, so it just becomes more intriguing. But on the other hand, you have to keep up to date because there's always these CPD points that you also have to get, all these continued professional development stuff, so that keeps me up to date basically of what's going on in medicine. So therefore I consult twice a week as well, which you think is too little.
And the patients always ask where you are, so he's not sleeping, he's actually busy operating in theatre till
Yes,
3 a.m. in the morning.
So yes, when I say I'm in theatre, some of my patients have asked me, is that the state theatre you're talking about? So, no, it's just a balanced type of doing things, and then I like the hypertensive patients and I like the hypercholesterolemia patients, and so that's where we sort of get together with the diet and stuff like that. Yes.
So thank you so much for being here today.
It's a pleasure, thank you.
Taking
Honor.
time out of theatre to be here. I think one of the reasons why we got you on the Zetlife series is because we have so many questions about hormones and intermittent fasting, and obviously being a doctor you have so much more knowledge on that. So the first question I have, there's this new fad about intermittent fasting. So we have patients trying to fast, for 12 hours,
yes.
which for me is more acceptable because you sleep 8 hours out
yes.
of the time. But then you have patients who want to fast for 48 hours. So what do you think about that?
Now, to start off with, the intermittent fasting is a funny thing because people always say, and it is said in articles also, that it's a controversial thing that has come on the scene. And when we talk about controversial stuff, it means that there's really not enough studies done about it. Now, when we talk about a study, it's very important for the patients to know this. When I see a patient and Elzette sees a patient and you talk about something, you need to know that if you want to speak in terms of academic terms, because as we know, medicine is not an exact science. Something didn't just fall out of the air to tell us that your blood pressure is 120/80. It's all based on statistics. So, and when we talk statistics, we need a few things. And the most important thing is what we talk about in statistics is a p-value. Now, everybody will tell me, okay, what the hell is a p-value? And I will also ask the statistician what is a p-value.
I only got 50 for research, so I also want to know.
You also want to
But at university, that's a pass.
That's still a pass. Well, when you come to a p-value, it's funny how it's determined. It is determined via a whole lot of mathematical studies or calculations that's being done. But what it basically tells you is if the study that you've done is statistically significant, and the p-value represents a number that gives us a percentage of the chances that you are wrong with the statement that you give on the hypothesis that you have. So if I, for example, tell you that the p-value was 0.05, it means that there's a 5% chance that your study is wrong. And that's where statistically significant p-value starts. It needs to be between a 0.05 and a 0.01. which means the 0.01 means that you've only got 1% chance of your study of something being wrong. So if a patient comes to you and they say, well, I've read about this and I've read about this study and that study, you always have to ask them, what's the p-value? Because that will immediately tell you, firstly, if the patient really read the study, because Dr. Google is a major thing, and you will see that there's people that will quote stuff that comes out of testimonials. People will say, I have got fibromyalgia, and the people on this support group tells me that this and this and this is my symptoms. Then I always ask, but what does the study say? And studies are done through universities, and the p-value gets also determined by the amount of people that's in a study, because that's where the big difference between a testimonial and the study comes in. In a testimonial, you will read 5 people tell you, oh, this product that I've used is so great, but 5 cannot give you a decent p-value. There has to be at least between 100 to 1,000 patients in a study to give us a decent p-value, and then that p-value still has to be significantly, statistically significant. So my problem with this is that patients, when they start looking up things, they have to start looking out for that. So now I've got the baseline of statistics, now we can go to the intermittent fasting. The funny thing about intermittent fasting and the controversy about it is that they have decent studies where the p-value is below 0.05, but there's not enough studies. So not only do you need one study, you need a few of that, and then you put all of those studies again together to get another p-value. So you see where I'm getting at. And the problem is that you have to look at that always when you do things. To give an example, we always thought that aspirin was a terrible thing. When I studied medicine, third year pharmacology, aspirin was a big no-no because it burns your stomach, and the amount of stomach cancers in those days that were associated with overuse of aspirin was major. So we were taught never to use aspirin. Aspirin these days are making a huge comeback, not only as low dose aspirin, as you know, that thins the blood for cardiovascular people, but also as an anti-inflammatory. It's still, till today, the best anti-inflammatory that you can get. The problem is the side effects. So studies these days are working on to get a medicine that gives us aspirin without the side effects. And that's the same with intermittent fasting. The studies are just too little to tell you that this will be the alpha and omega of a diet plan. What I have read up about is the following, that the intermittent fasting, and there was a big study in 2017 done by Harvard University. And as you all know, Harvard, it's not in the movies like it's this major university, it's in real life a major university. I would give my front teeth to have gone and studied medicine there. Nevertheless, they did a study, and the study showed that the results that you get with a balanced diet plan versus intermittent fasting was exactly the same. But the kicker is here, that they took another study from the University of Alabama, where the University of Alabama took 100 obese male patients which also had insulin resistance, which means that they had a heightened chance of getting diabetes. And I'll get to that sugar diabetes thing again, because it's the worst name you can get for a sickness, because it's got actually nothing to do with sugar. So that's where people get confused. So they took these insulin resistant obese men and they gave them an intermittent fasting of from 7 o'clock in the morning till 3 o'clock the afternoon they could eat. And then they used to fast after that. And what they found is that not only did these men lose weight, they did not lose muscle mass, and they actually improved their insulin levels, so they got rid of their insulin resistance. So in that aspect, total fan of intermittent fasting. But again, you cannot go and say, well, everybody now goes on intermittent fasting. That's where you come in. I don't have enough knowledge on that, but you have to then take patient by patient. And yes, it is a big thing now, but actually it's just another form of treatment that you can consider for your patients.
I agree. Thank you. I also think, like with patients, I often see females struggle more with intermittent fasting. I tried it for a while as well, and it just seems that males can do it a lot easier. And then some of the benefits of intermittent fasting is obviously more stable blood glucose levels.
Yes,
but
definitely.
If you do, like we do, a low carb, healthy fat diet, we see similar results.
Precisely.
So like you said, it depends on what the patient wants. If
Precisely.
somebody says, I want to eat, I wake up, I'm hungry, you can't force somebody to fast.
No, and that's the thing. But what for me, what was nice is that they didn't say that this is the only thing that we should use these days. And the other thing is that, okay, and it was only in male patient, but that's then a form that you can use in obese male patients with insulin resistance. There was definitely, and then the males would always say, oh, I'm so scared I'm going to lose my muscles or whatever, and I'm just going to get thin all over. Those males didn't have any muscle, that they basically lost muscle or anything like that. So, but the insulin levels got correct, and which is nice because you can turn around insulin resistance, you can't turn around diabetes. So that's where it comes in, where us doctors treat insulin resistance with drugs too. And that's why I sometimes find that patients, and that goes for diabetes patients, it goes for insulin resistance patients, it goes for cholesterol patients, it goes for hypertension patients. Everybody just wants a quick fix. So, doctor, don't tell me how to eat or whatever, just give me the tablets. Life doesn't work like that, never mind medicine. So, the more treatment methods we get, the better we can give options then to the patient. But no quick fixes, doesn't exist.
And at the end of the day, we just want to help people.
No, that's all, I tell my patients that all the time. I didn't wake up this morning to come give you bad news and to tell you what you should do with your life. I'm here, you come and see me because you've got a problem. So I've got empathy with that, I care about you, and I give you a solution to the problem. And I try to work with you because, as I explained again, there's now options to the solution. There's not only one solution. So now we've got options to solutions, and it's not only one solution, so I cannot tell you what you must do, but I can give you some options. So surely somewhere you have to start working with us.
Definitely. So then on the intermittent fasting, obviously if you eat a low carb diet, so what we do is we still include a little bit of yogurt, for example, for the calcium, vitamin D, low GI fruits like strawberries, but obviously that requires a certain amount of insulin secretion. Yes, it's less than having a bowl of cereal with a banana and low-fat milk, but how does that compare when you're fasting? Obviously then there's no insulin.
Yeah, you see now, that was the thing I think that they did in this study too, is that they and that's the whole thing about fasting, is that you try and reactivate your pancreas, because you talked about insulin now, and that's where I'm going to work from diabetes backwards. Sugar diabetes, worst name to call it. It's got nothing to do with sugar. It's got to do with your insulin levels. Now, the insulin levels are determined by the amount of glucose that you have in your bloodstream. So they are directly connotation-wise, they direct in the same way. So if your glucose level rises, your insulin level rises. Very easy. The problem is the cells, if I can call it in layman's terms, gets used to that amount of insulin that you secrete every day.
I normally say they get sick and tired, so that's even worse.
Precisely. So what happens is, even if you are now spiking your insulin levels all the time, and you then try to turn over a new leaf, in the beginning you are going to suffer, because your cells are used to this high insulin level, and the cell will only uptake the glucose because that's the function of insulin. And that's what a lot of people don't understand. Insulin is a hormone. Now, a hormone is a chemical messenger, like a nerve in your body is an electric messenger. So the insulin gets secreted to tell the cells to open up a sort of portal, I can call it a portal or whatever, to then get the glucose inside your cell where it's metabolized. Glucose in your bloodstream means nothing. It's not the place where it should be. So that's why to call it sugar diabetes is not wrong. It is actually a question of your insulin that goes too low. Now you'll ask me, okay, but how does my insulin go too low? Because my pancreas will just give insulin all the time as my sugar rises. And that's where people get it wrong too. Because the pancreas will actually at a stage get tired of producing that amount of insulin, and then your insulin levels will drop. Your glucose levels will go up, your insulin levels will go drop. Now, I cannot take a needle and put it into a cell to actually test someone's glucose in the cell. That would be ideal, because that's when we'll know it's at the right place. So the only way we can do it is to take blood and take your glucose. But it means then conversely that if your glucose in your blood is too high, then there is too little glucose in your cells because it's in your blood plasma. And that's where you then start realizing, oh hell, I can't only test the patient's glucose, I must test their insulin too. Because if you then test their insulin and you see their insulin is too low but their glucose is high, the lab actually does it for us these days. They give us what we call a quickie index. It's an index or a ratio between your glucose and your insulin. And if that is not correct, you'll see that there's a problem either with the patient's insulin or glucose or both. And that is where we then start getting problems. Now there is definition to diabetes. Definition to diabetes is very easy. If you do a random glucose in a person and it's above 11.1, I don't care if you can climb Mount Everest, you are a diabetic from then onwards. And then fasting, 7.6. Insulin levels differs because there's actually diabetics that have a normal insulin level at that stage when you test their blood, but their glucose is 11.1. But that's where you come in, because you try and regulate the insulin for the patient, and therefore by regulating the insulin, you make the cells used to a normal insulin level, and therefore the glucose level will become normal. But if your pancreas are tired of producing insulin, there's no way that you can reactivate your pancreas to start producing insulin again.
Well, you can make the cells more insulin sensitive.
Precisely. So with the little insulin that you have then in your pancreas to secrete still, you can only do the variable that is the cells to make them more insulin to the little levels to uptake the glucose better. And that's exactly where you come in. Again, patients come to me and say, don't tell me all this and don't explain all this to me, just give me the tablets. And it doesn't work that way. That's where you play an integral part.
So do no harm.
Yeah, precisely. Luan, quite correct.
Our camera guy.
Yeah, Luan is not only a camera guy, he's a patient of mine as well. So, and Luan is, I have to get my story straight when I talk to Luan, because he goes and reads up the correct stuff. So then he punches me with questions. So definitely, Luan is quite
Me
correct.
as well, I'm married to him.
Yeah, it's just like heavy stress on me for all the questions.
Do you have anything else to add on the insulin and the fasting?
Elzette, yes. Unfortunately, the fasting will help with your insulin resistance because you're not a diabetic yet. If you're a diabetic, I do not know if intermittent fasting will then be the right thing, because it's actually, in my opinion, a contraindication, because you are making a person not eat regularly, so they don't get a regular glucose feed. So if they, for example, take their tablets 3 times a day, but they're only allowed to eat from 7 to 3, what happens the rest of the day? Then their sugar will fall too low and they'll get all those problems. So no, you cannot, and again, that's why intermittent fasting isn't the beginning and the end all, because it differs from patient to patient. Also in that article there was mention of people with thyroid problems that can't do intermittent fasting. There were mention of pregnant ladies, all those things. So again, it's not for the patient or the person to decide. You have to consult someone which knows all the scenarios of all the types of academic types of way to eat correctly.
And that's why Michelle and I will always sit an hour with each and every patient. You can't do one meal plan for entire family. Each and every one is different. So you have to really come and speak to a medical professional.
Well, that's the thing. And us doctors like if I refer a patient to a specialist, I like to get a letter back to tell me what happened to the patient, what the specialist think, or whatever, because sometimes the patient wants to know from their house doctor that they've had for me, for example, for 19 years, what is the opinion now. So, and that's the thing that patients need to realize. If your house doctor or a specialist referred to a dietitian, make sure that dietitian communicates with a medical doctor as well, because it's a whole team experience, a whole team that needs to work on you, and so that everybody's just on the same page. Because if you start contradicting each other, and it's very easy to do that, because I would for example think in my limited knowledge that this diet will be good for you, and then Elzette comes and she writes me a letter and says, well, we've looked at all the scenarios and this is the best diet, then it's a wrong thing. And the same thing with Elzette. Elzette has come to me with blood results, with medications that patients are taking, whatever, to get my opinion, because that influences the way you eat and the way you're going to lose weight as well.
Yes, and thank you so much for all your assistance
No,
through the
easy.
2 years.
It's easy.
So thank you so much, Dr. Andre. We're going to wrap this video up.
Excellent.
Stay tuned. We're going to do more videos on hormones, thyroid, and all of that. So stay tuned. If you have any questions, please comment in the comments section, and have a wonderful day. Bye.